Good afternoon, ladies and gentlemen. Today I will talk about comparison of reason constituted between conventional ultrasonography and sonazole contrast-intensive ultrasonography as pre-treatment evaluation of percutaneous RF ablation of small HCC less than 3 cm and 1.5 cm wireless. When pathologists consult about percutaneous US-guided RFA of small HCC with the ablation list, first we perform US as pre-treatment evaluation of breast tumor in order to assess vision conspicuity, organ contact, size, test, and distinct effect. Vision conspicuity is a very important factor in order to place the electrode in the center of the tumor accurately. The purpose of this study was to compare vision conspicuity between conventional US and sonazole CUS. Our study population consists of 17 patients who had 22 small HCC less than 3 cm and had pre-treatment evaluation including conventional and sonazole CUS. Among them, 14 HCC were 1.5 cm or less. All tumors were diagnosed by EOB MRI. We used the GE logic 9 machine with a convex and linear probe back in the CUS with low MRI. Pre-treatment evaluation performed conventional US first and sonazole CUS second, both in the same session. And then vision conspicuity of this tumor was evaluated by consensus of two external radiologists as a 3-point scale: grade 1, clearly defined; grade 2, defined to degrade RFA possible; grade 3, and poorly defined to degrade RFA impossible. We analyzed statistically through US imaging regarding grade of vision conspicuity. Protocol of sonazole CUS consists of a vascular and post-vascular phase. You can usually get vascular imaging approximately 20 seconds after injection and get Cooper imaging after approximately about 10 minutes. The advantage of the sonazole CUS is in Cooper image. There is a stable image from about 10 minutes to more than 60 minutes. So it's effective for guidance for RFA electrode. Let me show you the result in practice. We can usually average small HCC with grade 1 or 2 vision conspicuity. The number of vision conspicuity on grade 1 and 2 on conventional US was 77.3%. That of sonazole CUS was 90.9%. In 14 HCC with the size of 1.5 cm or less, the number of grade 1 and 2 in conventional US was 10, 71.4%. And that on sonazole CUS was 13, 92.8%. 4 tumors of grade 3 on conventional US were well visualized on sonazole CUS. In summary, vision conspicuity of sonazole CUS was statistically not significant compared with the conventional US. This could be due to a small sample size, but percentage of grade 1 and 2 sonazole CUS is higher than that of conventional US. 21.4 percentage point in 1.5 cm wireless. It tends to improve vision conspicuity of a small HCC, especially if this HCC is 1.5 cm wireless. Let me show you 2 examples of vision conspicuity grade 3, grade 1. First case was a 54-year-old male patient with 1.59 cm HCC in segment 6. EOB MRI showed typical HCC findings with a irregular margin. On conventional US, we can find the nodule by sonazole CUS, hypovascular nodule in vascular imaging. Here. With defect in Cooper image. We performed Cooper image guided RFA. The tumor was completely abled. This is the second example. 79-year-old male patient with 3 cm HCC and segment 8, 1.0 cm HCC in segment 7, EOB MRI shows hypovascular nodule in segment 7 with the defect in hepatobiliary phase, T2 high signal with N diffusion restriction. So we diagnosed probably hypovascular well-differentiated HCC. Conventional US didn't show the nodule, but here you can see the round defect in Cooper imaging. So we also performed Cooper image guided RFA. The tumor was completely elevated. This table shows two cases of small HCC with grade 1 and grade 3 in lesion QD. In this case, sonazole CUS was inferior compared to conventional US, low defect in Cooper image. This findings show in case of well-differentiated HCC with Cooper cell or hypoechoing nodule. Let me show you two examples of lesion constituted grade 1 and grade 3. EOB MRI show typical HCC findings with hypovascular nodule. Conventional US show clearly defined grade 1. Sonazole CUS show low defect in Cooper image due to uptake of sonazole by Cooper cell in the nodule. Here's the second example. EOB MRI show typical fatty HCC findings with the signal dropping out of phase. Conventional US show clearly defined hypoechoing nodules, grade 1, but sonazole CUS show no defect on Cooper image. In conclusion, sonazole CUS seems to be effective in improving lesion constitutivity for RFA of small HCC, especially those that are 1.5 or less in size. Thank you for your listening.
Thank you, Chairman. And in Japan, our microwave system is old style, and so many defecting than European and American new one. But basic microwave, magnetron, and microwave is still the same. And so I experience of radio frequency aberration. So, and recently, maybe 3 or 4 years before, I imagined that change the protocol microwave. So I practiced small experimental study. So today I would like to introduce our result. So the aberration effect of microwave energy differ fundamentally from that radio frequency energy. And the microwave energy radiation make a higher tissue temperature than radio frequency energy. And microwave aberration may provide a more homogeneous and predictable, because the microwave directly aberrated and surrounding tissue, but radio frequency is current, electric currency makes tissue temperature by the impedance. So the microwave aberration is create more homogeneous and predictable aberration zone depending on microwave energy irradiation. But it may lead to serious complications sometimes with charge because of a high temperature surrounding the antenna and surrounding the microwave antenna. So we report experimental results of a new intermittent microwave irradiation. And still, I have already explained the difference between microwave aberration and radio frequency aberration. So near the microwave antenna, the microwave effect is directly goes to tissue, so the very strong to the heat sink effect. And but roughly say, the microwave need the molecular rotation to create the tissue temperature. However, the radio frequency is need some kind of electrolyte through the electric currency increase tissue temperature. That's the difference between a microwave and a radio frequency ablation. However, this effect is not clearly divided, but roughly say the microwave ablation is a molecular rotation and the radio frequency ablation is electric currency. And so this is a very informative result. So you can see here the blue line, the microwave, the tissue temperature is rise up within a second. However, the radio frequency needs more period, and depend on the role of the radio frequency ablation tissue temperature is almost less than 100. However, the surrounding microwave tissue, the temperature is rise up more than 150, and it may create this serious complication sometimes in past Japan. So the Japanese doctor hesitate to use such kind of very effective microwave ablation. And so microwave can increase the tissue temperature during seconds, and so a shorter period of microwave irradiation may be better. And the microwave energy decline half-life in every 1 centimeter. So the higher energy microwave irradiation will be better. So the Fred Reed in Wisconsin said is I believe that's correct. And protecting the child tissue around an antenna and intermittent energy irradiation may give a benefit of microwave. So I imagine this protocol. So first of all, I practice a conventional microwave experiment. The microwave equipment is older one, and the protocol is microwave protocol is 80 watts and 10-second irradiation and 5-second rest. And this cycle is repeated in 10 times and 20 times and 30 times. And the conventional is 80 watt and 1 minute continuous irradiation. So this protocol is compared in experiments. So you can see here the right side is a conventional Japanese conventional protocol, and it creates the diameter, and the short axis is 1.5 centimeter. And intermittent protocol creates repeated 10 times is almost 2 centimeter, and the 20 times makes more than 2.5, and the 30 times recycling create more than 3 centimeter diameter. So this is the result of our experiment. So we can understand a repeatable short period of irradiation and short rest, and repeat this cycle may create it dependent on the cycles. Then I wonder why this phenomenon is occurred. So I check the standing wave ratio of microwave. It means that the irradiation energy and the refraction energy by measuring the voltage of refraction energy and the refraction energy. So this experiment is very old style. And so I check our protocol by voltage standing wave ratio. This is the result of standing wave ratio. You can see here that red line is lowest, and it is 10-second irradiation and 5-second rest, and repeat is the line. And the highest line is the continuous irradiation. So you can see here that standing wave ratio is also maintained a lower level. It means that reflection is lower. And so microwave ablation might provide a more homogeneous and intermediate protocol create a larger ablation zone. And so finally, comparing the tissue temperature during microwave ablation. And so you can see here that the blue line is the intermittent protocol and the red line is a continuous protocol. You can see here that intermittent protocol is lower than continuous one, more than 10, 15, or 20 centimeter degree around the antenna. So it may lead that the complication rate more lower, I guess. And finally, I create a larger ablation on the multi-antenna method. This method experiment is a prototype of equipment, so we cannot use in Japan. And so you can see here that right upper is a 50 watt and continuous 60 second, and the same energy, and right upper one is a 50 watt and 30 cycle. And the diameter of ablated zone is more than 4 centimeter. And right lower is 80 watt in the 60-second continuous ablation. And left row is intermittent 80 watt and 30 cycle. You can see here that the diameter is apparently increased. And distance over antenna is 3 centimeter. So finally, my conclusion is intermittent protocol may create a larger ablation zone with a lower tissue temperature. And triplet antenna can make more larger ablation zone, almost 6 centimeter in one ablation within 8 minutes. And so let me show that recent clinical case and metastatic stomach cancer and with liver metastasis. So you can see here that 2 sessions of 30 cycle and 1 session of 30 cycle and 20 cycle and 25 cycle. So you can see here the diameter of the ablated area is depend on cycles. Thank you for your attention.
Good afternoon, audience and moderator. It's a great honor to give this presentation about cutaneous coagulation of renal tumor. I'm Dai Wei-Ren from Taipei Veteran General Hospital. My instructor is Dr. Shen Junhui. As introduced in the Dr. Shen Junhui's slide, the cutaneous coagulation is a minimal invasive surgical technique. It induces cell lysis by fast cooling of the tissue to a lethal temperature. In previous studies, it showed comparable results as compared to partial nephrectomy. And the American Urological Association guidelines says that our ablation as well as radiofrequency ablation is an alternative treatment to partial nephrectomy for renal tumors, not larger than 3.5 centimeters when surgery is contraindicated. And some papers suggest 4 centimeters as cutoff value, and 4 centimeters is stage 1A for renal cell carcinoma. We retrospectively review our patient list from October 2009 to August 2013. And these patients were found to have renal tumors on image study and referred from urologists due to surgical contraindication. And we reviewed the pre-procedure image and recorded the tumor characteristics, including the size and the growth pattern, location, and the relation with renal pelvis. We did our ablation by CT guidance, and We plan the trajectory and the number of the quadruples on the procedure image, and during the procedure, we inserted the quadruple according to our plan and started the freezing cycle. And during the freezing cycle, we did cascade every 5 minutes to monitor the growth of the ice ball. The bottom image were from a real case. After insertion of the quadruple, we started the freezing cycle. And after 5 minutes, the cascade demonstrated the ice ball as a well-defined low-density area, which had not yet extended beyond the tumor margin. So we kept on the freezing cycle, and after 15 minutes, we can see the ice ball had extended beyond the tumor margin by at least 5 millimeters. And this is the first requirement for the technique success. The other requirement was a complete freezing passive sewing in the freezing cycle. And after achievement of technique success, we did active sewing with liquid helium for ready removal of the quadruple. And hydrodissection is one of the techniques that we use in the procedure. And for example, this patient had a viral tumor, and which was in close contact with the hepatic fracture of the colon. So in the procedure, we inserted a fine needle and injected a diluted contrast medium into the potential space between the lesion and the colon to separate them. And after cryoablation, we can see the ice ball did not involve the colon. And if the lesion was adjacent to ureter, we request the preoperative preventive retrograde double-J ureteral stent insertion in case of accidental damage of the ureter. Besides, we consider the usage of balloon spacing technique. And under CT and the fluoroscopy guidance, we inserted a balloon catheter into the potential space between the lesion and the protected structure, which in this case is the ureter. And we inflated the balloon with room air or a diluted contrast medium to separate them. And after cryoablation, the ice ball did not involve the ureter. About the procedure follow-up, we checked the weight-based electronic medical record for the complications and determine the severity by Clavier needle calcification. And for RCC patients, we checked the oncological outcome. If there was distal tumor within 6 months and after cryoablation, we call it incomplete ablation. If there was distal tumor at least 6 months after cryoablation, we call it local recurrence. And we also check for the presence of the distant metastasis. And we recorded the pre-procedure creatinine and the other value at 3 to 6 months after cryoablation and calculate the GFR.